Hello, and this is part C of Chapter 7, and in this part we are going to talk about another piece of data that you can obtain from the pulmonary artery catheter, and that is the pulmonary arterial pressure, both the systolic and diastolic. And this is following the discussion I just had on the central venous pressure, and in the first section of this chapter we talked about the basic anatomy and placement of the pulmonary artery catheter, So back to my silly little diagram of the pulmonary artery catheter that has been wedged. And again, what's the first step is you deflate that balloon. Get that balloon down. I don't want any pulmonary infarctions or ruptures because those are very bad. Make you feel very bad. I've fortunately at this point never seen one. So how do we measure the pulmonary artery pressures? Well, it's transduced from the very tip of the catheter here, and as we talked about in the first part, you get this nice pulmonary artery systolic pressure, this dicrotic notch, and the pulmonary artery diastolic pressure. And again, the pulmonary artery systolic pressure normally is well below 30, and the diastolic pressure can range sort of between 4 and 15, and the pulmonary artery diastolic pressure is a very good surrogate, barring any abnormalities in pulmonary vascular resistance. The pulmonary arterial diastolic pressure is a very good surrogate for your pulmonary arterial occlusion pressure, or your wedge pressure, as is commonly referred to. Okay, pulmonary arterial pressure. As I mentioned, the systolic pressure tracks the right ventricular systolic pressure, barring any significant pulmonary arterial outflow tract obstruction. And the genesis of the pulmonary artery diastolic pressure is from the pulmonary vascular resistance. The resistance through the pulmonary vascular tree imparts this resistance to flow, and therefore a back pressure is generated, which causes the pulmonic valve to snap back, and the diastolic pressure is created. The pulmonary artery pressure is related to the right ventricular stroke volume and the impedance of the pulmonary arterial tree. So the greater your stroke volume, the greater it's essentially directly related to the pulse pressure. So the greater the stroke volume, the greater the difference between the pulmonary arterial systolic and diastolic pressure, and the relative values of those pressures will vary based on the impedance to flow. And again, we talked about impedance in Chapter 2. That impedance is a physiologic parameter that is a better measure of afterload in distensible blood vessels. It is the geometrical summation of both classical resistance, which we all learned about, I think, in undergrad physics. Classical resistance being most sensitive to changes in the cross-sectional radius of the tube through which the gas or fluid is flowing. But also because blood vessels are distensible, the impedance takes into consideration something called a reactance, which is related to the compliance of the blood vessels. So I want to talk a little bit about, on that note, a little bit about the afterload of the right ventricle. The pulmonary arterial pressure per se is not the afterload of the right ventricle. As I mentioned, it's the impedance. And I see this very frequently in the intensive care unit, and I hear a lot of very smart people make this mistake, and this slides might actually ruffle some feathers, but I hope to dispel some mystery. This principle is most apparent when a patient performs a Valsalva or bears down with a pulmonary arterial catheter in place. While the pulmonary pressures will rise with the Valsalva, both the pulmonary arterial tree and the right ventricle are exposed to the same intrathoracic pressure, and therefore this is not, I repeat, a Valsalva-induced increase in pulmonary artery pressures is not a true increase in the impedance to flow. Okay, and I want to demonstrate that with some cartoons here. So this is your pulmonary artery pressures that you're measuring. This catheter is in place. Now let's say, hypothetically, I've floated this PA catheter in one of those Olympic weightlifters, one of those huge guys that's about to lift a school bus over his head, and you are measuring his PA systolics as he lifts this massive amount of weight above his head. Well, what you're going to see is a dramatic increase in the pressure around the heart and blood vessels and lungs. The whole intrathoracic, or the whole thoracic box, I should say, is pressurized, and your PA pressures will increase. Okay, let's see that again. It's going to float up sky high. Let's say it doubles up to 60. Well, 60 millimeters of mercury as a PA systolic is going to be pretty scary, but is it going to instantaneously kill this weightlifter? No, because there's no true increase in the RV wall stress here, because the right ventricle and the PA, the pulmonary arteries and the pulmonary arterioles are seeing the exact same increase in pressure. So this is not, I repeat, not an afterload on the RV. In this situation, you may actually see the pulmonary arterial pulse pressure diminish, and that's because your right ventricular stroke volume is diminishing as you Valsalva. And why is that? Well, I'm about to talk about why that is. Okay. So the Valsalva can be dangerous. The physiology of the Valsalva can be dangerous, especially in patients with pulmonary hypertension. This is the patient population I hear this all the time in. You know, you're going to intubate this patient with pulmonary hypertension, and you want to prevent them from valsalving because you'll increase their right ventricular systolic pressure, and their RV can't tolerate that, and they'll go into cardiovascular collapse and die. That is not true. That is just not what is happening physiologically. The reason is that the increase in is not the increase in pulmonary arterial pressure. It is dangerous in patients with pulmonary hypertension for two reasons. First, patients with severe pulmonary hypertension have a fixed high impedance to flow in the pulmonary artery. So this physiology kind of mimics aortic stenosis on the left side. So Valsalva will drop your venous return precipitously, and these patients are preload dependent. They rely on their end diastolic volume for stroke volume because they can't lower their end systolic volume much because of the high impedance to flow. So these patients will lose their cardiac output from Valsalvaing, but it is not the increase in pulmonary pressures, it is the drop in venous return. Secondly, then this is kind of semantics, but a Valsalva is technically an increase in intrathoracic pressure without a change in lung volume. But if these patients quote-unquote Valsalva, they bear down, increase their intrathoracic pressure, but at the same time they lower their lung volume, well, that will increase pulmonary vascular resistance. Lowering lung volume will below functional residual capacity will increase pulmonary vascular resistance. But again, it is not the increase in intrathoracic pressure per se. So just to go over these two mechanisms for Valsalva in the right ventricle, with particular emphasis placed on the patients with severe pulmonary hypertension, this is the Sagawa pressure volume relationship of the right ventricle. And again, the right ventricle, the shape of this curve is kind of slurred compared to the left ventricle, and the reason it's kind of slurred like this, particularly here after peak systolic elastance, is that actually ejection continues, unlike the left ventricle. In the left ventricle, you hit peak systolic elastance, and you have an abrupt drop in pressure, and you hit your end systolic volume. But ejection actually tends to occur in the right ventricle because of the low pulmonary arterial impedance and systolic ventricular interdependence. That is, as the left ventricle contracts, there's maintained a pressure gradient in the right ventricle, which maintains its ejection past peak systolic elastance. So qualitatively, the shape of this curve is somewhat different from the left ventricle. And again, in Chapter 2, we talked about this curve here, this summation curve, this arterial elastance. Here it's the pulmonary arterial elastance. The slope of this curve is a summative score for the impedance to flow for the right ventricle, and it's the relative ratio of the slope of arterial elastance to end systolic ventricular elastance. This defines so-called ventriculovascular coupling, which is a marker of how efficient the heart is able to eject blood into the arterial tree. Okay, so in a patient with pulmonary hypertension, they have a dramatic increase in this impedance to flow. The elastance is much increased. Okay, and this is essentially fixed in severe pulmonary hypertension. So now these patients eject and they strike the end systolic pressure-volume relationship way up here, and so now they have this relatively high and fixed end systolic volume that cannot be reduced because of this high impedance. So you can imagine if this patient valsalvas and they drop their end diastolic volume, well, the difference between your end systolic volume and your end diastolic volume is your stroke volume, and that will severely impair your cardiac output. So this is really an illustration of why Valsalva and destroying venous return to the pulmonary hypertensive patient is dangerous. Secondly, as I mentioned, that your pulmonary vascular resistance is defined by the relative capacitances of the extraalveolar and alveolar blood vessels. So vascular resistance of the extraalveolar vessels decreases as lung volume increases, whereas the vascular resistance of the intraalveolar vessels increases as lung volume is increased. Did I say that correctly? The vascular resistance of the intraalveolar vessels increases with lung volume, yes, as they are compressed. So that looks like this, and therefore your summative pulmonary vascular resistance is kind of U-shaped. So it's lowest at functional residual capacity. So as I mentioned, if that patient increases their intrathoracic pressures, but at the same time they drop their FRC, they will increase their pulmonary vascular resistance and they will increase right ventricular afterload. But again, this is not a function of the Valsalva and the increase in intrathoracic pressure itself. This is a function of the drop in lung volume. If the patient's lung volume does not change, their pulmonary vascular resistance will not change, and therefore the afterload of the right ventricle will not change. Okay, pulmonary arterial pressure. An increase in the PA pressure as a result of an intrinsic increase in the impedance to flow will afterload the RV, and this is in contrast to the Valsalva. So let's take that same Olympic weightlifter who we talked about, who increased his RVSP to 60 during Valsalva, and he was still able to lift that weight. He maybe got a little bit lightheaded and quite red in the face, but he tolerated the RVSP of 60. But if you were to increase the RVSP in the same weightlifter by, say, injecting plastic beads into his inferior vena cava, which I do not suggest that you do, but if you did and you injected those beads just into a point when his RVSP reached the same 60 millimeters of mercury, that patient may actually drop dead. So same RVSP, but very different hemodynamic effects. So this would be like a pulmonary embolus. So let's demonstrate that. So here comes the bad clot. Pow. Okay, you have now caused an intrinsic increase in the impedance to flow. Your pulmonary arterial pressures increase by the same amount as Valsalva, but this has a very, very different hemodynamic effect. This actually could be instantly fatal because the RV can no longer handle this strain, and the wall strain on the RV goes up abruptly and can result very quickly in coronary ischemia, right ventricular pressure overload, collapse of the left ventricular cavity by diastolic ventricular interdependence, and frankly cardiogenic shock. Okay, so that is my talk on pulmonary arterial pressures, which leads me into a discussion on pulmonary vascular resistance, which we had in Chapter 2, but I'd just like to re-emphasize it here because this is another misconception I see in the intensive care unit all the time. And this one's a little bit confusing, and it's sometimes hard to explain to people, but I think the PowerPoint graphics lend themselves nicely to this principle. So we calculate the pulmonary vascular resistance by measuring the mean pulmonary arterial pressure. So you get this from your PA catheter. It's just like measuring the mean arterial pressure, but you're using your pulmonary artery systolic and pulmonary artery diastolic pressures to determine your mean pulmonary arterial pressure. You subtract from that the pulmonary artery occlusion pressure, your wedge pressure. So your mean pressure less your occlusion pressure is the driving pressure across the pulmonary vascular circuit. Driving pressure, and then you divide that by the flow, or the cardiac output, which we will talk about 2 sections from now. Next section we talk about the occlusion pressure. Okay, so this defines your pulmonary vascular resistance. And roughly a normal value for PVR is these impossibly confusing dynes per seconds per centimeter to the fifth of 20 to 130. Okay, I try not to focus on this because I find the pulmonary vascular resistance to be meaningless is kind of a strong word, but confusing and misleading, I think, are probably the two best adjectives for the calculated pulmonary vascular resistance. And that is the reason I'm going to describe to you now. And again, I see very intelligent cardiac anesthesiologists, pulmonologists, and cardiologists making this mistake, but you're not. Changes in pulmonary vascular resistance must be interpreted with extreme caution because the pulmonary vascular bed operates as a series of parallel Starling resistors. Remember Starling resistors we talked about in Chapter 2, and that is when blood vessels, when the pressure within a collapsible blood vessel drops below its ambient pressure, you actually get collapse of the blood vessel, and this creates kind of this fluttering resistor effect. And most notably, this occurs in the IVC. It also occurs in West Zone 2 physiology. It was this vascular waterfall effect, I believe was initially described in the early 60s by Saul Permut. It's like a 61 or 62 paper. It's kind of a classic. So therefore, you can get calculated changes in pulmonary vascular resistance without any change in the properties of the vascular bed at all, and vice versa. So simply lowering your cardiac output will result in a calculated increase in your pulmonary vascular resistance, even though there's been no changes in the intrinsic properties of the pulmonary vascular bed. And the reason is the pulmonary vascular bed has a tremendous, and this physiology actually somewhat applies to the systemic vascular bed as well. So using the SVR, the systemic vascular resistance, as a marker of left ventricular afterload is equally problematic, but I don't want to get into that right now because my head might explode. So the pulmonary vascular bed has a tremendous potential for parallel recruitment as driving pressure increases. This phenomenon decreases resistance as pressure increases, so flow progressively increases. So there's not a linear relationship here. It's actually an exponential relationship. And then individual blood vessels in the pulmonary tree are themselves distensible, so that as their internal pressure, as the internal transmural pressure of these vessels increases, their radius increases, which then decreases the resistance and then exponentially increases flow. The net effect is that it's erroneous to assume that the vascular bed has a linear, i.e. pressure flow, slope, rise over run, however you want to calculate it. Pressure over flow is a linear relationship, resistance variable. The effective resistance is constantly changing with changes in driving pressure. So let's depict this graphically. Pulmonary vascular resistance, this is the driving pressure across the pulmonary vascular circuit. So this is your mean pulmonary pressure less your wedge pressure. This is your pulmonary blood flow, or the thermodilution cardiac output, however you want to obtain it. Okay. So this is the assumption of a linear relationship between pressure and flow. This would be a decreased vascular resistance. So why would that be a decreased vascular resistance? Well, if you choose a driving pressure here at this pressure volume relation, or pressure flow relationship, sorry, you have a flow that's low, but at the same pressure in this variable you have a flow that's very high. So for the same pressure, the flow is greater. This would give you a calculated decreased vascular resistance. Similarly, by the same argument, this would give you an increased vascular resistance. Problem is, pressure-flow relationship is not linear. It's not even close to linear. It's curvilinear, okay? So this is how you can get false positives and false negatives. How's that going to work? Well, say you add a vasoactive substance, or you change the mechanical ventilator setting somehow, which lowers the driving pressure across the pulmonary vascular circuit, but also drops your blood flow simultaneously. So from here to here, you've dropped the driving pressure, but you've also significantly dropped the flow. If you were to calculate simply driving pressure over flow, you would now have a slope, or a value on the slope here, which would give you a calculated increased vascular resistance. But you can see that because this line is curvilinear, there's actually been absolutely no change in the properties of the pulmonary vascular bed. So this is particularly important, and you need to be on guard when you're making changes, and these changes could be, changing the dose of epinephrine, changing the amount of PEEP, adding inhaled Flolan. All of these things, you need to not just make this lump score pulmonary vascular resistance. You need to be very specific in what are the changes in driving pressure and what are the changes in blood flow when you make a specific intervention. And if they change in the same direction, i.e. driving pressure drops and blood flow drops, you got to be careful, because you could be fooling yourself. False negatives also occur. So imagine in this patient you truly have changed the properties of the pulmonary vascular bed. You've shifted this curve rightwards, which would in effect be an increase, or would sort of actually truly be an increase in your pulmonary vascular resistance. An example of this might be a large pulmonary embolus or a bad consolidation causing hypoxic vasoconstriction, which causes an increased vascular resistance in one zone of the lung, but blood flows away from that portion of bad lung and flows to good lung, and then it causes recruitment and distension of the other blood vessels. So there's actually no effective change in the pulmonary vascular resistance. Okay, you'll calculate this pressure flow relationship to this pressure flow relationship, and there'll be no change in the slope, but in fact there actually has been a very significant change in the properties of the pulmonary vascular bed. And again, in this situation, both pressure and flow have increased. So when they move in the same direction, you got to watch yourself. This physiology is also the reason why when you're in the pulmonary hypertension lab and you're doing tests for vasodilator responses, like you've got a patient with pulmonary hypertension and you floated a PA catheter and you've given them some inhaled nitric oxide, and you want to see if there's been truly a change in their pulmonary vascular bed. Well, this definition has changed recently. I believe, I can't remember how many years ago it was, but it used to be just defined as a change in your pulmonary vascular resistance. But once this physiology was elucidated, people realized that changes in pulmonary vascular resistance can occur without any real changes in the pulmonary vascular bed. So now what is the definition? Well, you have to have a decrease in your mean pulmonary artery pressure. So there's got to be a defined drop in your mean pulmonary artery pressure. It actually has to drop by 10 and to less than 40. So you're guaranteed that you're shifting leftward on the x-axis. And on the y-axis, there's this red line here, which I've put to demonstrate that there has to be no decrease in blood flow. So a positive vasodilator challenge means that the driving pressure has dropped and there's been no drop or even an increase in pulmonary blood flow. And if you choose that as your definition of a vasodilator response, it's going to make detecting a true left shift in this curvilinear pulmonary vascular resistance, it's going to make detecting that more likely. So that is why a positive vasodilator challenge is defined the way it is today. And that was it for, what was that, part 3, pulmonary artery pressures. We will move on to the following section shortly, and that is the good old-fashioned pulmonary artery occlusion pressure.